when we are dealing with a patient, the most important thing for anything is the history, right? We have been told right from the third year that history is one of the most important things, and that is what Dr. Garde also told you regarding the oroantral communication and maxillary sinus conditions, that even for ankylosis, history is very important, right? So what happens is we have to obtain the mechanism of injury from other observer if it is possible. If it is possible, what is the time of injury? Now this time of injury refers to the golden period and the platinum minutes, that if there is extensive trauma, we can handle it very well. We also have to note for amnesia, ENT bleed, vomiting, orientation to time and place, because this will tell you whether the patient has suffered a head injury, right? And of course, a brief medical history is important so that we can institute the proper treatment. Okay. Now, the first thing that one has to deal with is the primary survey. In primary survey, if by that I mean that if you are a dental graduate or a postgraduate student in maxillofacial surgery, one should not rush seeing a fracture of the face and try to deal with it. There could be some underlying systemic cause that can cause a lot of problems. So what we need to do to check in primary survey is airway, breathing, circulation, very importantly spine injury, abdomen, look at the abdomen, the chest, the cranium and the nerves, right? And of course the ocular movement. These are the most integral part or a vital part in primary survey, right? Now, what is important in primary survey is the Glasgow Coma scale. Now, the Glasgow Coma scale was given by in GNET in the year 1974, and this you can remember by a small mnemonic called as EM, that is eye movement, verbal response and motor response, by which there are marks assigned, points assigned to each particular condition, and the best score would be 15. That means the patient has got spontaneous eye movement, spontaneous obeying, and the patient is oriented. However, if there is no response to the eye, if there is no response to motor commands, to give motor commands, and if there is no verbal response, then obviously the score is 3, and that is the worst prognosis that a patient can have. So you can just remember EVM for the Glasgow Coma scale. Now, Glasgow Coma scale is not particularly restricted to trauma. It can also be used in patients who are moribund patients who got stroke. So these are all the situations where we can use the GCS. It's very important to know GCS. Now, the next important thing, what happens in a motor vehicle accident is a whiplash injury. So in whiplash injury, what happens is, like I told you earlier, the patient tends to move forward with the motion of the car, and when there's sudden deceleration, the patient can either head and neck can go forward, or it can get hyperextended, right? Hyperflexion or hyperextended. So in such a case, what can happen is that the cervical vertebrae can get crushed, right? There can be a ligamentous injury, and this is a very critical, crucial situation, because also when the head, if you look here, if the head moves forward, the brain tends to move backward in a limited space and can cause damage to the brain. At the same time, when the head moves backward, the brain would tend to move forward. So one has to be very careful when observing these patients of maxillofacial trauma. Again, in primary survey, we look for head injury, whiplash, massive hemorrhage, thorax and abdomen, cardiac tamponade, so on and so forth, right? These are the most important things. Now, when we have a patient who is lying on the ground with a motor vehicle accident, one should be very careful to transport the patient, right? There could be a chance, unless proven otherwise, that the patient is having a cervical fracture. So, in such a case, we need to stabilize the neck, and this can now, in India, unfortunately, we are yet to improve our standards to the advanced country standards. So normally if an ambulance comes, the patient is shifted. Now these ambulances in advanced countries would have something called as the Laerdal Stiffneck, which is a semi-rigid cervical collar, and this allows for temporary immobilization of the cervical spine. But since we are known to improvise a lot, what we do is that we can just put 2 sandbags, and if sandbags is not available, we can use rolled up bed sheets or towels and keep it by the side of the neck like this, right? So this is the simplest thing that one can do. If not, if all these facilities are available, then we can use this cervical collar. Now this will prevent the movement of the neck and will be not damaging to the cervical spine. Now once we ruled out the cervical spine fractures, what we need to do is we need to maintain the airway. And by maintaining the airway, we can do a chin lift. That means we cup the forehead of the patient in a C grip, and hyperextended. At the same time, we put our thumb or 2 fingers below the mentum and pull the mandible forward. Otherwise, what we can also do is to keep 4 fingers behind the mandible, the angle of the mandible, and drag it forward. So that 2 things happen. First is the movement of the tongue is prevented, which goes back. At the same time, the airway patency is maintained by dragging the mandible up, right? The other simple thing that one can do is to put these Guedel's airways, right? Earlier they were made of metal, now you've got good plastic ones. And the way to introduce them is to see that the convexity of this tube matches the concavity of the tube matches the concavity of the palate. And then once it goes in the oropharyngeal region, it is turned so that the tongue doesn't get pushed back by the movement of the airway, right? So that is the way to do it. Now, if the patient has got an obstruction or if the patient is severely compromised in airway, we need to do a tracheostomy. And which are the situations that you can do the tracheostomy? When you got a fracture of the cribriform plate, that means that there is an extensive head injury, right? You got the tongue falling back, okay? So when the tongue is falling back and there's an upper airway obstruction, one needs to put a tracheostomy. The second thing is the patient could have a lot of secretions that will block the airway, and also the fact that the patient has got a fracture of the ribs, right, whereby the patient cannot expand the chest properly. So these are all situations where one needs to do a tracheostomy. Now, a tracheostomy itself is a big discussion which we can do. If you do not have a tracheostomy, we can just insert a wide bore needle between the thyroid and the cricoid cartilages, so that the what is known as cricothyrotomy, and this can provide a temporary airway till such time that we manage the patient properly. Now, the secondary survey, this cannot begin before the primary survey is done. So the primary survey consists of airway, breathing, circulation, right? If any disability is there, and then you have to expose the patient completely. Okay? So what are the parts of the secondary survey? You need to do what is known as sample. Now, this particular slide you see says ample, but you can add an S before it. That is symptoms, allergies, medications, past medical history, the last meal, and the events surrounding the injury. That means what has precipitated that injury. That is a big thing. Because see, normally if somebody is riding just a cycle, falls down, then the type of injury which will happen is much lesser than what a patient who is sitting in a car without a restraint and moving very fast can happen, right? So the secondary survey begins in the sequence of head, cervical spine, neck, chest, abdomen, perineum, rectum. Now, how do you do that? You wear gloved hands, right? And then you put your gloves on the hands, and then you move your hand in one smooth motion, going back, examining the chest, going at the back, and frequently observing if there is any blood or anything, right? So this is the way one needs to do it. The musculature system, this includes examining the limbs. So when you are examining the leg or the arms, you need to move it in one particular fashion so that you do not miss out any fracture, right? Then after that, you come to the maxillofacial structures and examine it properly. And also one should look for thermal burns, because sometimes, when you fall off the car, you could get dragged, and that can cause a thermal burn also. Okay. Now, what can happen? We come to the proper secondary survey, right? If there is any trauma, maxillofacial trauma, there could be mid-face fractures, Then there could be dentoalveolar fractures, and lastly, you got the mandibular fractures. Okay. So first we'll go as per what we have talked about, right? So the imaging for trauma is extremely important. You got PA mandible or Waters view, the lateral oblique view of mandible. Now, not in all centers you're going to have facilities for CT scan. CT scan is the gold standard. If CT scan facility is not available, then one can go in for various, X-rays. I think Dr. Sharan is going to deal with imaging, right? So you can go with X-rays, and then when the patient is transported to a tertiary care center, you can get a CT scan done. Now, CT scan is there in 3 sections. That is the axial section, the coronal section, and the sagittal section, right? So these are the 3 things which are important, and then you got the 3D reformatted images, which can tell you a lot of details. But however, as a purist, one should always look for the basic sections of the scan. Now, in a dental college setting or usually in a dental setting, you got the OPG, which is the best help, and it gives you a lot of information. Like when you observe here, there is a fracture of the angle of the mandible, right? And it has got displaced. It's a horizontally unfavorable fracture. This is the 3D reconstructed section where you see a fracture of the parasymphysis, right? So it is needless to say, CT scan is the gold standard for your imaging. And Viva question that can be asked is the Campbell lines and the Trapnell lines. Now, the Trapnell lines were added at the end, which is at the inferior border of the mandible. Now, when you look at these lines, just follow them in an X-ray and you will come to know which bone has got fractured, right? This is the significance of Campbell and Trapnell lines.